Welcome, everyone, to the first live and in-person edition of Editors in Conversation. My name is Ellie Thiel. I'm an editor for the Journal of Clinical Microbiology. I also have a day job as a lab director at Mayo Clinic. And I co-host this podcast with Dr. Alex McAdam, our fearless leader and editor-in-chief of the Journal of Clinical Microbiology. And Alex, thanks to your incessant promotion of Editors in Conversation on social media and live and in person, I think you should be proud of yourself, of the crowd you've drawn.
I think we have a pretty good crowd. I want to ask the audience a question. How many of you are subscribers to Editors in Conversation? So for those who are listening and cannot see the audience, there's about 700 people here, and every single one of them just raised their hand.
Thank you, Alex, for that slight exaggeration. So for those of you that have not subscribed to Editors in Conversation, just a little bit of background. So there's two podcasts. So Alex and I co-host the Editors in Conversation podcast for the Journal of Clinical Microbiology. It's a monthly podcast where we really highlight a recent publication in JCM, invite the authors to come speak and talk about their manuscript. And then we have a sister podcast or brother podcast that is hosted by Dr. Cesar Arias, who is editor-in-chief of Antimicrobial Agents and Chemotherapy. So both of the podcasts are sponsored by the American Society for Microbiology, and we ask that if you do not subscribe, give them a try. They're educational, sometimes funny, sometimes not funny, but definitely educational. So rate them and give them a try. And one other housekeeping item before we get in, I would like to acknowledge and thank Mr. Ray Ortega. So Ray, if you could please wave, bow, jump up and down. So Ray is really the mastermind behind these podcasts. He makes Alex and I both look and sound good, which sometimes takes some effort. So thank you, Ray, for all of your help. Okay, so with that, I am very excited to introduce our guest for today, Dr. Bobbi Pritt. So many of you probably have heard of or have met Dr. Pritt. She is known for many things. One of my favorites, though, is her blog, Creepy, Dreadful, Wonderful Parasites, where she highlights a case a week, both that has come through your lab or that has been donated from international or other laboratories. And you're at like 600 in some cases?
Yeah, 600 and almost 690.
Which is like 13 years of cases?
Yeah, I've been doing this since 2007.
Yeah, so a lot of educational content. I think I used it to study for boards. A lot of us probably still use it to study. So if you have not seen it, give it a look. But aside from blogging, Alex?
It's on Twitter as well.
Yes,
right?
I tweet out the cases. My handle's Parasite Gal.
Yes. So outside of blogging about parasites, Dr. Pritt does have a day job. She is currently the chair of the Division of Clinical Microbiology at Mayo Clinic. She directs the Parasitology lab at Mayo, and she is a professor of laboratory medicine and pathology at Mayo. So thank you, Bobbi, for joining us.
Well, thank you, Ellie and Alex. It's a real pleasure to be here for this inaugural session.
Inaugural, and hopefully maybe not last, but we'll see. So we're going to cover a number of topics in the next 25 or so minutes, but I've worked with you for 10, 12-ish years, and I realized I don't actually know what got you into parasitology. Like, did you wake up one day and say, I am going to be a world expert in clinical parasitology? So, can you share with us what got you hooked?
Yeah,
on worms?
Well, I think I always loved biology, and parasitology is just, it's biology just in miniature, right? But you have worms that have little life cycles and hosts. It's all biology, and I was always drawn to that. So I was the kid with the pocket of snakes, and the worms and stuff. It's true. I'll tell you that story sometime. But yeah, I had a pocket full of snakes. And I also really enjoyed art, and I personally think that parasites are really visually beautiful. So they're creepy, dreadful, and wonderful. And so I thought for the longest time I was going to be an artist before I finally changed to biology and then ended up going to medical school, probably because I like dissecting things and I thought pathology would be a good career. So that's how I became a pathologist. And then I discovered that I really liked infectious things more than I liked tumors. Tumors are okay, but I just really thought that infectious things were cool. So I went into microbiology. How I was able to be a parasitologist, though, that was just luck. It was my favorite subject, but it also just so happened that my mentor, Dr. John Rosenblatt, retired, and they were looking for a clinical parasitologist at Mayo. And then they said, oh, and by the way, you could go to London and get a master's in parasitology. And I said, okay, I'll work here for sure. So that's the path.
So you did not have a parasitic disease.
No parasitic diseases, and hopefully none still. Yeah.
Sounds good. So you've been a parasitologist for many years, and you've seen hundreds, maybe thousands of cases. So I was wondering if you could share with us a case that really stood out, and you're like, wow, that was unexpected. Do you have a case like that?
Yeah, I do, and I actually came prepared with props. So this is a bit of a disturbing case for those of you that want to leave or stop listening for a moment. I wouldn't be offended. So we get all sorts of cool cases at Mayo Clinic. In our laboratory, we get specimens from all around the world. And so I've certainly seen a number of really awesome cases. But the one that really stands out in my mind was actually not, well, I won't give away the punchline yet, but I think you'll agree it was a very interesting case. So I'll tell you the story. So it was a middle-aged man that presented with recurrent bladder infections. And that's all we knew initially. But when you have bladder infections as a male, you worry that there's something wrong, something structural. And it turned out he had a giant stone in his bladder, like the size of a fist almost. And when they went in and took it out, which they had to do because they couldn't just take it out non-invasively, they had to do open cystolithotomy. And they cut it open and there was a worm inside. So they were freaked out. The Metals lab, which does the renal stone analysis, was freaked out because they don't usually get worms. So they sent it to me, and it was indeed a worm. It was about, how long is that? Like the length of my palm, maybe?
5 inches, maybe?
Yeah, okay, that works, about 5 inches. And so, I don't know, I won't put the audience on the spot, but like all of you listening, you just think like, what worm is 5 inches and can be found in the bladder? Ascaris might be that long, but how the heck would it have gotten into the bladder? There is a worm called Dioctophyma renale, which is the giant kidney worm. So for a while, I thought it could be that. I also thought, could it be a foreign body, like a part of a catheter? I mean, this guy had this for years. It was all encrusted with stones. Well, then I realized I had seen something like this before. I had dissected it, and there was nothing inside. And you guys remember if you've ever dissected like an earthworm, there's like parts inside. There's an intestinal tract, and this had none of that. It was spongy and amorphous. And I said, this looks a lot like a fishing lure that I had seen, and I actually had in the lab because 4 years prior, I had taken these lovely fishing worms and I had put them in a jar and I submitted them to my lab on April Fool's Day, along with some water, and I added a little cocoa powder to make it look kind of like a specimen. And we had accessioned it, stools, April, so April stools. And everyone was like, oh, Dr. Pritt, you're so funny. Okay, they're rubber fishing worms. And I had this in a vial and I put it on my shelf and it sat there, and here we are 4 years later, and I'm like, oh my gosh, this looks a lot like these rubber fishing lures. And so I'm going to take one out. So we put them side by side. They were morphologically identical. Because we did infrared crystal chromatography on it, and they showed the exact same peaks. So I said, I think this is a rubber fishing lure, and I don't know why it was in this guy's bladder. But they went back to the patient and asked him, and it turns out that he had indeed inserted this in his urethra, and it just never came out. So, bit of a disturbing story. But, Ellie, this is for you.
Oh. Thank you,
I think
Dr.
I need a minute before
Alex,
we go
would
on.
you like one too?
No, thank you.
Here, Alex. So, so I remember this case, and I was like, why do you have this plastic worm in a jar that is exactly like the worm out of this individual's. I mean, what are the chances?
How would my April Fool's joke have turned into an aid for making a diagnosis in a real case?
Yeah, it's
Total
crazy.
craziness. So that really is my craziest, most memorable case.
And I will point out that if any of you are interested in more of the details, Dr. Brian Schmidt in the back over there did write this up as a case report back when JCM accepted case reports. It is very
2012, it was published, JCM.
Yes.
I think he became known for a little while as the foreign body guy, maybe?
Yes.
Sorry, Brian.
So
Be careful what you publish.
yeah, and thank you, Dr. Pritt, for taking a potentially X-rated situation and converting it into a PG-13 material.
Good.
So
I was hoping it would be
thank
appropriate.
You for that. All right, so we're going to switch gears,
Okay.
maybe to safer gears. So aside from being a parasitologist kind of, at home, you also have had a number of international training initiatives. I think most recently you came back from Uganda. So I was wondering, I'm hearing more and more from our trainees and other individuals in our field that are interested in starting or participating in kind of international health projects or studies. So can you tell us a little bit about the initiative that you have and your experience?
So I was definitely interested in global health, probably because parasitology, so many parasites are endemic in resource-limited settings, and we think of that as tropical medicine, global health. And also I had done my master's in parasitology and got a diploma in tropical medicine and hygiene at that time. So I kind of already had this interest. But then when I came back to Mayo Clinic in Minnesota, returning from London, I was asked to help teach a global health course up at the University of Minnesota. So I've been doing that since 2008. I've been giving 4 labs up there, and people come from all around the country to learn tropical medicine so they can then go out and practice. The University of Minnesota's session is the only one that's endorsed by the CDC, so people come from all over. Well, it was so successful, the University of Minnesota's course, that they branched out to Thailand, which I would love to go to sometime, but I haven't been yet. But then they started a brand new East African version of their course in Uganda, and that was right before the pandemic. It was January 2020, and we went and started a course there. Of course, you really, when you do global health, you want it to be a good partnership with a stable partner. You want to know that you're going there to do capacity building. You don't want to just go in, do something, and then leave. So we really partnered with the microbiologists there, the global health physicians. It was a little challenging going and starting up a teaching lab in Uganda because it's not like I could bring, I guess I could bring this, the rubber worms, but I can't bring a big jar of Ascaris on the plane. And you can't necessarily ship things, they don't make it through customs. So we sourced things locally. We made a lot of contacts, and some people brought things, and then I brought slides. So we've done it once, and we're going back again in 2023.
That's awesome. So what do you think has been one of the biggest challenges? So bringing material.
Sourcing material, making sure that you have local expertise and that you're really capacity building. You really want to eventually, with the goal, it's to make yourself obsolete. Or to continue to be more serving as a consultant. But you really want to empower the folks that are local so that this is beneficial to them. You don't want to have a negative footprint. So we were worried we were going to go back last year, but then we thought, well, what if we all get COVID there? And then we're overwhelming the local hospitals, and what does that do? And then, of course, we're all stuck there trying to quarantine and all of that. So, those are all considerations too.
Yeah, Ellie, you have done a little bit of global health outreach, I think, as well. Would you tell us about that?
Yeah, so I co-lead an initiative in Belize, and I've partnered with one of our ID clinicians at Mayo Clinic and then 2 entomologists at the University of Notre Dame. And we have I like to think of it as a very rounded initiative, looking at vector-borne diseases in Belize. Our entomologists colleagues had worked there for over 10 years, so they had made inroads. And so our our initiative is really looking at multiple tiers of vector-borne diseases. So the entomologists are looking to identify what vectors are there. We know there's a lot of mosquitoes, but nobody really knew what tick species, for example, were there. So we've done a lot of tick drags. I dragged Dr. Pritt with us one time to do some more tick drags. And then, so identify the vectors. We've done seroprevalence studies to look at what blood donors are, have been exposed to. And one interesting thing we found is that there's a very high seroprevalence rate of for spotted fever group rickettsia, which is interesting because the clinicians were not aware of that, which is a treatable infection, and the labs didn't test for it. So one of the other tiers that our ID colleague is leading is education around vector-borne diseases, both for clinicians as well as the public through various different means. And then from the laboratory side, we really wanted to do capacity building, but also education. So one thing we did for the Central Medical Lab in Belize is really kind of focus in on the QSEs, quality systems essentials, everything from improving quality assurance, quality control, things to bringing in new tests for Zika, for dengue, and soon for rickettsia. So it's been very rewarding for sure, but it's been a lesson in patience because you can go and do all these things and just say, okay, go. We gave you the tools, start using them, but it's just not the way it works. So it's been rewarding and educational, and hopefully now that COVID is less COVID, we can go back. But
Yeah, if there are people in the audience, we could talk to you afterwards, but really finding a good partner, a good collaboration, but then also just learning the local, the way the lab operates. And usually something like proficiency testing is so important, but may not be part of what they do. Often people are trained on the job and then don't receive any type of ongoing competency assessment. Obviously, access to different tests, reagents is variable. And sometimes people get donations of equipment, but as soon as the equipment stops functioning, there's no local representative to come and fix it. So really, sustainability is such a key part of it. And Ellie, what you've been doing in Belize is amazing.
Well, thank you. It's been a huge team effort. But yeah, if anyone's interested in how to get involved with global health, feel free to track us down afterwards. So kind of wrapping it up, we've talked about where you started, where you've been, and I was wondering if you could tell us a little bit about what you see as the future of parasitology being in clinical labs in particular.
Yeah, I'd be happy to. I see right now, in the next 5 to 10 years, a continued need for morphologic skills. We still need people who can look at things. Not everything should get chopped up and, sequenced. So basic morphology will remain important. But I also really see digital pathology as being really helpful, especially when you can take a slide and screen and detect things and actually increase your detection rate. So you can more easily diagnose malaria. Maybe every time someone gets a CBC, wouldn't it be great if you could also pick up if that person has malaria, just make it routine? We're looking at it for blood exams, stool exams, and in our lab and most labs across the country, 95 to 97% of our exams are negative. So our technologists are using their time at the microscope just screening out negatives, and it's not always very rewarding for them. So wouldn't it be great if we could use digital pathology, deep convoluted neural networks to identify parasites, or at least slides that might have parasites present, so then the techs can really use their expertise to figure out what's there, rather than just mindless, just screening negative after negative and then running the risk that you're going to miss something just because of user fatigue. So I think that those are big trends. Of course, shotgun metagenomics is going to play a role too. And I'll just end with a cool thought that some of our bacteria actually have 16S ribosomal RNA, the genes, because like the apicoplex, the apicomplexins, like toxoplasma, that could actually be detected because it was a bacterial endosymbiont event millions of years ago. So sometimes we're actually doing bacterial sequencing and detecting parasites. But when we move to shotgun metagenomics, we're going to be detecting parasites, I think, that we hadn't even thought of before.
So as more and more automation comes in and digital pathology and all that, I was wondering if you can kind of share with us how we are handling concerns that we get from technologists that, their expertise may become obsolete. So how are we dealing with some of those concerns?
Yeah, that's a great question, and my techs will ask me that, but I think in my laboratory we've been very clear that we're not replacing them. We need every single one of them, and you all know about the workforce shortages across the country. So the technology we're implementing is really so that they could use their skills better. So instead of looking at negative after negative after negative slides, that they could actually focus in on the things that might actually have a parasite and then kind of dig into what it is and challenge themselves. And that's been well received. Actually, I've already had my tech starting to ask me if they could read the slides from home. And I'm like, we're not there yet, maybe someday, but for now, let's just implement it in the lab for routine care.
We had very much the same conversation about MALDI-TOF, right, some years back, where people were concerned that with the implementation of MALDI-TOF, there would be less need for technologists, but that hasn't been the case at all. MALDI-TOF is now widely used, widely accepted, but we still have a tremendous shortage of technologists, and I cannot see that ending.
And Alex, you had a good, is it metaphor or comparison about digital pathology?
I was talking with Jan Rhodes at the Clinical Virology Symposium just, a month or so ago, and we were talking about artificial intelligence and machine learning, and we came to the conclusion that artificial intelligence and machine learning is where PCR was about 25 years ago. It is beginning to be used in the larger reference laboratories. Manufacturers are beginning to look at it, they're beginning to be very interested in it, and I think with some time it's going to become part of our routine. So visual interpretation of colony morphology, for example, will become increasingly automated and driven by these systems. And if you think about it, chromogr is the lowest hanging fruit for this sort of thing. Those are very simple images, or very simple things to interpret visually, but I think it will build over time, and I suspect that 25 years from now, it will be established in the laboratory as part of our routine.
Well, and we talked about global health. Think about how that might impact resource-limited settings where maybe they can take a picture of something, but they don't have the local expertise to then figure out what to do next. There's nothing to say that someone can't take a picture of a plate and in real time say, that's the colony you should work up. I mean, that's something that we should be considering when people don't have local expertise, but they have maybe some scanning equipment or photography.
Absolutely. Well, I want to take a minute and thank you, Dr. Pritt, for joining us. We didn't get any tomatoes thrown at us, so I think this went well. But thank you so much for sharing your expertise and for everything you do from an educational component for clinical microbiology. I'll put in a last plug for the Editors and Conversation podcast. Please do subscribe. They're fun, and who knows, maybe you'll be our guest sometime, right? Any closing words?
That would be terrific.
Alex? No? All right. Well, thank you very much.
Thank you for having me. It's been great.
Thank you, Bobby. Thank you, Alex.